we're going to be guarding the affected side, which would be, in this case, her left side, because we're always going to transfer towards the strong side. So again, this is first time working with the patient. If their strong leg was, you know, fairly weak, I might be more prone to guarding that side, because if that leg buckles, she's going down. If there was a surgery on like her affected knee, I would not guard that side, because she has a wound on her anterior knee, and I do not want to cause my patient any pain. So a knee replacement, I would guard the left or her right side, which would be unaffected. But generally, we are going to guard the affected side. So I will just, for now, to make it easy, we'll say it was an ACL. She's non-weight bearing. If she's non-weight bearing on her affected side, you also would not guard that side, correct? I've seen that happen before, and that was an auto fail. So there's on the rubric, there's like just generally unsafe, but things that we don't list. That's one of the few times that someone failed because something that wasn't listed. So you're going to be non-weight bearing on this side, which means I'm going to be guarding this leg. I don't want to be all up over here, because now I'm going to be in her way. So again, I'm kind of bringing my knee forward. I might actually bring both knees here. This leg, no weight bearing through it, okay? I actually am going to angle this chair a little bit less to give us a little bit more room. But you have good arm strength, so you're going to help push yourself up. 1, 2, 3. And now you need to pivot and turn. You can hold on to me. Very good. And sit. I probably could have angled her foot a little bit more in the direction that she was going to be sitting to make that a little bit easier. But otherwise, you're really guarding that leg to make sure she doesn't go down.
And note, guys, that Dr. Parker's feet were not in between the patient's feet. Okay, that's something that I see a lot, that they're like really in between both feet.
My knees were here, but my feet weren't here.
Exactly.
So get
Try
comfortable.
not to get in between their legs. Right.
The knees are okay.
Yes.
Okay, let's come on back over. Now, if it was a stroke patient, her left side is affected. She's able to bear some weight through her leg, but it's very weak. Say she's like a 4 out of 5 on this side, generally like a 2 out of 5 on this side. She doesn't have any control with her arm. She's going to be able to use her right arm to help her come up to stand. She should be okay standing on her right leg, especially if there's no surgery or anything. She should be good here, so now I'm going to guard her affected leg, but everything else is the same. So your left arm is pretty much staying here. You're stuck in what's called a synergy pattern, so you can't really use this arm. And then 1, 2, 3, up to stand. And now I'm guarding her affected leg, and then she's coming to sit. So this is the one that there's going to be the most variation in how this is performed based on the diagnosis, whereas the rest of the transfers all look pretty similar most of the times you do it. If it's dependent, it doesn't matter if they're a 1 or a 2. They're less than a 3 all over. You're doing all the work. Slide board, lateral swing, you're helping them figure it out. It might look different depending how much they can do, but it looks the same. Standing dependent, they're generally weak. You're guarding both sides. There's not any particular thing you're worried about. You're just making sure they get there. This one, stroke looks different than knee replacement, looks different than hip replacement. So there's a lot of variation with this one. So there might be a few cases that you would probably need to choose this one. So for now, let's just practice generally how to do it. We will then do a gross muscle test, and then towards the end, ideally we'll be able to talk about some more of the specific scenarios and try and get some time in with that, because we want you to have some exposure to those differences before coming back next time. I'm going to email Dr. San Lucas and make sure she focuses on maybe getting some case scenarios for you guys to think through a little bit sooner than potentially planned. Just because, like I said, next time I see you, we are testing on this. So, you got a question?
Yeah, so why are you affecting, or why are you protecting the affected side on a stroke, but you're protecting the unaffected side on a, replacement? What's the reasoning behind that? It's like the opposite.
Because it's like fragile, or you don't want to touch it?
Well,
Yeah, so that's if she had a knee replacement on her left side, there's probably going to be a wound here, and I'm not going to want to put any pressure over that wound if she's going to buckle and fall. I would probably, again, we're kind of thinking the first time we're doing this, total knees, total hips, generally there are not weight-bearing precautions anymore. Generally they are weight-bearing as tolerated. So a patient that's coming up onto their affected like surgical side, it might be painful, so they might not want to put much weight through there anyways. So more of their weight would be on their affected side or their unaffected side, which is why I would want to guard that side. So the total knee is 100%. You're guarding their unaffected side because of the wound on the knee. The total hip, we will expect that you do guard the affected side still for here, but clinically, depending on where they're at and what I'm seeing, it depends how much weight I feel they're comfortably putting through that leg. If they're putting weight through this side, then I want to guard this side because I don't want them to put weight and it gets painful and then they fall. But if they're like, I don't like putting weight on this leg right now, then I need to be on their strong leg because now they're basically like non-weight bearing on this side. And if this leg buckles, they're going down. Does that make sense?
So what about the stroke that seems backwards?
So the stroke, they are able to bear weight through their affected side. It's very weak. They don't have good motor control. But I am trying to get them to bear weight through that leg.
And you're pretty confident with the other side because the other side's unaffected?
Yes.
Okay.
If I had reason to believe that the other side, if they were just recovering, if there was like any surgery involved and they're like woozy, then I'm more concerned about the strong side and not having them bear weight through their affected side.
It's a limiting process of how much they don't collapse.
Yeah, exactly. It's basically relative to how much weight I feel like they're trying to put through affected versus unaffected. Where do I need to be to keep the patient safest? So that's where the decision-making piece comes in, particularly with this transfer. There's more to think about than with the other ones. So for now, let's just practice, like we can go through those 3 scenarios, get comfortable with where you would be standing. You want to always transfer towards the strong side. Their foot position, like I said, angle them a little bit towards the direction that they're going to be sitting, so that especially if they're non-weight bearing, they basically have to do like a little hopping motion. If they're bearing weight on both sides, then it's a little bit easier to turn. So a lot more to think about here. So, you know, the standing dependent, you're not really thinking about a whole lot other than don't let them fall. Practice that once, but go through and think about the couple scenarios we just went